Hello, good morning. I'm Ashok Rokade, consultant rhinologist and anterior-skull-based surgeon from Winchester and the University Hospital Southampton, UK. I welcome colleagues from around the world on behalf of organizing team to this inaugural Winter Global Rhinology Endoscopic Sinus and Anterior-skull-based surgery webathon. Global Rhinology Network is a registered non-profit organization with a mission to foster surgical education in rhinology and skull-based surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We will have hugely informative and engaging sessions presented by eminent rhinologists and skull-based surgeons from around the world. GRACE 2020 is hosted at the Global Telemedicine Studio of Professor Wilco Groneman in Utrecht in Netherlands. It is supported by Medtronic and Karl Storz. Thank you.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology, featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
So next, we're going to proceed with our next great speaker. So we have Dr. Anshul Sama. All right. He's a consultant and honorary professor at Loughborough University. He completed his clinical fellowship in rhinology at Monash Medical Centre in Melbourne, Australia. He's an ex-council member of the British Rhinology Society and the past secretary of the Rhinology section of the Royal Society of Medicine. He has been section editor in rhinology for current opinions in excuse me, Otorhinolaryngology since 2009 and ENT Masterclass since 2008. Dr. Sama will be presenting on management of mucoceles. Thank you, Dr. Sama.
Thank you, Woodward. Woodward, I'm not sure where you dug that up from, but I've forgotten all of that. Thanks for reminding me. First thing I'm going to say, following Jim is going to be a very difficult act. So I'm going to kind of hang up straight away. I give up. But the remit Ashok has put to me is to talk about frontal mucoceles. And I've got to compliment Ashok for setting up such an amazing venture. It's astonishing the faculty that you managed to attract. I think the topics you've covered over the 2 days is going to be amazing. The delegates you're getting in, absolutely astonishing. Great work, Ashok. Keep it up. Thank you very much for the
Thanks,
advice.
Anshul.
Really appreciate
Thank you for your support as always. Thank you.
My pleasure. So I'm based in Nottingham in Midlands, and Ashok's worked with me in the past, which is a great pleasure, and lots of friends in the audience as well as in the panel. I'm going to talk about mucoceles, nice easy topic, but what I would like to start off with saying, and what I'm really going to do is share my philosophy of how I manage this particular entity. And the first and foremost thing to really say is that it is not a singular entity. It's like sinus disease. You know, there is a whole spectrum of condition that goes from simple unilateral maxillary sinusitis to ASA triad. And similarly here, what we have is you can have very simple mucoceles, which may be very large, expansile, but actually easily delivered, and others that can be significantly more challenging because of the anatomy or the pathology. So there is no one easy way of managing all of these frontal sinus mucoceles in the same way. So what I'm really going to share with you is how do I manage this? How do I think about it? What do I do with them? How do I manage them? Now, traditionally, we talked about this kind of ladder that we have, where we start off with green, the traffic light, I call it green to red, whereas the green is the kind of endoscopic, conservative, non-obliterative procedures. The orange are, sometimes we would go there, but not always as a primary procedure. And the reds, rarely in our current era do we do cranialization or obliteration procedures. Renals, I've done a few in my time, very minimal. However, when you've got something like mucocele or sinus disease, you don't actually walk up that ladder one at a time. You'll end up doing lots of different procedures. Sometimes you really would jump this and say, well, draft 2A, 2B, or even 3 sometimes is the primary procedure you're going to look at here. What I'm going to discuss is how and when do you consider that as an option. So with respect to the mucoceles, we wrote up this publication now quite a few years ago, 7 years ago, looking at the time. And we talked about really our algorithm of how we would look at the problem. Actually, the algorithm can be used for any form of frontal surgery. It is just specifically aimed at mucocele management here, but you could use the same principle for your consideration of frontal sinus surgery. Essentially, it's based on the position of the pathology, whether it's medial, lateral, or intermediate, and the different other anatomical or pathological factors that affect where you're going to be. So say, for instance, you've got a medial pathology with no significant anatomical other configurations, a type 1, 2A would be probably adequate to manage the problem. Whereas you have a more complex anatomy, which we'll look at in a little bit, you're likely to require much more invasive or larger antrostomies. What it basically comes down to, and this is my surgical philosophy for managing frontal sinus surgery, you have anatomical factors and you have pathological factors. And these factors will determine for you what kind of approach you're going to do. These are the considerations you have to have before you decide what kind of surgery you're going to be looking at. Anatomically, you're going to look at the position, as I just mentioned. Is the pathology medial or is it lateral within the frontal sinus? AP and lateral medial dimensions, that is the gateway through which you're going to be walking to try and access your pathology. How big is the door that allows you to get in? If the door is small, you might need to make sure you get as big an access as possible. Supraorbital cells is something that often catches people out. When you've got pansinusitis and you've got supraorbital disease, it sometimes diffuses is, or you don't pick it up when you're looking at your scans, and they can be very difficult entities to manage. And I'll talk about this a little bit further. Type 3, 4 cells, we know about it, we like to talk about them. As Jim says, it doesn't matter what you call them, they're all going to come out. These cells can sometimes be actually helpful, they sometimes can be problematic. When you're doing with mucoceles, they can usually be helpful because it means that your anteroposterior lateral medial dimension is going to be bigger, such that you don't really have to do much work because often the pathology would have done most of the work for you. Other factors that you do need to consider is pathological. And are you dealing with Samter's triad? Are you dealing with unilateral sinusitis? The degree of aggression will reflect that. The biggest problem that you're going to come across in my practice definitely is neosteogenesis or osteitis. You can call it what you like, but either way, that's the disease that's going to bite you back. That's the disease that leads to difficulty and the need for revision surgery. And last comment I would probably make is do not try to be aggressive or brave in an acute inflammatory disease. It will always shrink down and will always bite you back. Acute inflammatory infective episode, deal with the infection, let the disease settle down, and then do something definitive at a later stage where everything is controlled. Acute inflammation, everything closes down. So what do I mean by medial, lateral, and intermediate? There is actually no real definition. If you look at the literature, it's a little bit mixed about it. The way I've defined it and the way we defined it in our paper is any pathology that in a parasagittal plane is a medial to the orbital plate, we will call that a medial pathology. If it's lateral to a third of the orbital plate, in that its most medial presentation is lateral, then that becomes lateral, and anything in between is intermediate. So let's very quickly look at that because there is a lot of misconceptions related to that. So here, the first one, although the dehiscence in the orbit is quite lateral, the medial most presentation is what we need to consider. That's the pathology, that's the area that you're going to address. So this would be considered as a medial pathology. Whereas here, post-craniotomy, where you got an isolated supraorbital mucocele, the most medial presentation is lateral to the orbit. So I would call that intermediate. And when your pathology is isolated in a lateral component, then that's lateral. That's true lateral pathology. So that's one thing. The AP lateral medial dimensions, as I mentioned previously, that's the door. What's the size of the door? Sometimes the size of the door is affected by the pathology. Sometimes it's anatomically, genetically small. Sometimes it's what we do to the individual. So here's a person who's had a tube put in or a silastic tubing put in for a long-term drainage procedure, which very unusual nowadays in practice, but it does happen in some practices here. But to get that in, you've actually taken away the template that is going to hold that antrostomy open. So by drilling to put that drain in, you've actually taken away the buttress of bone that's going to maintain the patency to that. So sometimes it's created by us, sometimes it's created by pathology. If you've got aggressive mucocele, it's going to erode all the bone away. If you don't have an adequate drainage pathway, you've got a thick beak here, small AP-LM dimension. As you take the pathology out, the soft tissue is going to drop back in. It's going to close off your pathway. Got to anticipate what's going to happen. Has the pathology changed? What's going to happen? Pathology has changed here as well, because if you look at the degree of neosteogenesis and osteitis on the opposite side, you know you've got a lot of inflammatory load. You try and make a small tunnel to this pathology, the probability it's going to shrink down because you got narrow pathway and a lot of inflammatory load that's going to affect this area. Neosteogenesis, this is my demon. This is the thing that's really going to cause you the most degree of trouble. And this is what gives you the sleepless nights. This is what's going to cause you problem in the long term. You see this, think carefully whether you're capable of dealing with it, or send it to somebody who deals with this kind of pathology all the time, because I can assure you, you will have a long learning curve in dealing with this kind of problem. So we're going to kind of look at a few examples, and on the basis of which I'm going to really leave you with a few thoughts of what are important and what I've developed over time with my philosophy in managing frontal sinus disease, in particular mucocele. Why this person presented is quite obvious. He's obviously got diplopia, quite a lot of proptosis, the eye is being pushed out, and he's got a large mucocele. You can see big mucocele. You could keep thing being the medial presentation is medial to the orbital plate. So quite a large mucocele with erosion both on the orbital and the cranial plate, going all the way to the supraorbital component. Now, often with these big mucoceles, provided they present medial to the orbital plate, they've done the work for you. They've thinned the bone out. And here, this is really very much a case of drainage procedure. So although it's a huge mucocele, it's medial, it may have some intracranial extension, but the probability is, looking at that kind of grid, you're really looking at a 2A, 2B kind of approach to be able to resolve this problem. And that's what you really want to do. So you're really going to create an opening, but actually most of the opening's been done by the pathology for you already. All you're doing is uncapping the mucocele, and you have a very good drainage pathway for it. No drill involved here. This is purely done by the pathology. It's just a matter of taking the intermediary bone off. And then you'll see that the orbit does settle, but it often takes months for the eye to reposition itself in its natural position. But you've addressed the diplopia, which is the key thing. So let's look at something slightly different. And this one scan, you've seen it previously. So you've got a isolated mucocele on the left side superiorly, with almost complete obliteration with neosteogenesis between yourself and the drainage pathway. You then have a type 3 or 4 cell on the opposite side with an isolated frontal sinus disease on the opposite side as well. And if you look at the axial cuts, these are quite telling, where I would say that if more than 50% of the drainage pathway is been obliterated by neosteogenesis osteitis, think carefully. You will need to make a big hole, and you will need to look at how to cover the exposed bone very well, otherwise this disease is going to recur again. So in this kind of situation, you're really going to have, although that's still medial, but you got significant osteogenesis, but it's medial. So it's a medial pathology. More than 50% neosteogenesis, you've got bilateral disease. My preference here for first line of step would be type 3 or osteoplastic flap. And that's the way you're going to try and adequately manage that. So here I elect to do an osteoplastic flap to drill all that bone off, to get that neosteogenesis all drilled away, so I've got healthy bone, and then put some flaps in place to make sure that over time I'm going to get adequate drainage occurring for that area. I'm not going to talk about this in detail because Paolo Casanova is going to cover more extended approaches to frontal sinus tomorrow. What I'm going to talk about is what's really my workhorse for a lot of frontal sinus disease. And yes, I've done a lot of draft 3s, but progressively draft 2B with the use of mucosal flaps is a very sturdy operation and keeps it unilateral and a lot quicker healing process. So let's look at this pathology here. You've got an isolated mucocele with some quite significant osteitis already occurring, and you can see that the bone is thickened And obviously, it's dehiscent in certain parts into the orbit and the cranial plate as well. But there is also quite a lot of new bone that started to form between itself and the ethmoidal complex. Hence, your drainage pathway is really handicapped or obliterated by this new bone osteotic procedure. And you can see that his presentation was what would be a Potts-Puffy tumor, a pseudotumor with isolated abscess occurring into the forehead. So in this kind of situation, I think what I tend to use is the draft 2B, and I want to share with you some of the key factors that I tend to use here. This is about 4 or 5 years old, so it might, there are certain changes, but it actually illustrates the key questions. So I tend to use a needle now to create my flaps. The incision is slightly further back because I use both the posteriorly based flap and the septal laterally based flap at the same time. You make your incisions so that you know you're going to drill a lot of this bone away. So I'm planned here to do a draft 2B procedure. And obviously you get a lot of mucus. That's not the mucocele. That's just entering into the Aganese cell, etc. And what you then need to start looking at is to raise that mucosal flaps back. And the key thing is staying in that subperiosteal plane. Make sure you pick up the periosteum and you gently push this back. And the reason I do this is I want to identify the first and the most key landmark. You will see this groove is in the roof of the nasal cavity where the vessel runs is quite consistent. And what I'm trying to get to is the first penetrations that come from the skull base that identify for me the anterior-most component of the skull base. Once I've found that, I know that if I remain in front and lateral to that, I will be safe with my dissection. I prefer to use the rongeurs as much as possible rather than the drill if I can, but obviously that's not always feasible. But as much as possible, I'll use the rongeurs. Key thing here is I've always got those first penetrations from the skull base in my surgical field. I know exactly where the anterior skull base starts, and I know where my limit is, how far back I can go. So whilst I keep that in my vision, I'm comfortable going lateral, I'm comfortable going in front of this. The key thing to remember, yes, I have got the mucocele here, and this is where the whole theater says, oh, when all this pus pours out. But actually, that's only the start of the work. You've just opened it. Remember, the floor of the frontal sinus lies in front of these penetrations, and unless you remove those, you're really not going to get adequate drainage for this. And we know all that new osteogenesis we've got in there, as much as possible, we've got to remove all that new bone, the osteotic bone, to make sure we've got a good long-term result. So preserve all the mucosa, any mucosa you get. So I've got a little bit of mucosa left on my middle turbinate here. I'm going to cut that. I'm going to try and use that to flap it around to cover any degree of bone that I can. Always keeping that first penetration in view with my flap behind. You can see the orbits now open. Now this is an area that your rongeurs are not going to be adequate. You've really got to do the drilling work, and you've got to make the hole as big as possible. Otherwise, it will close down with all that new bone that's been forming. You've got to take all that new bone away. So you need to drill away till you can see the frontal wall with a 0-degree scope. Now, I know that Jim and a lot of people work with angle scopes. I tend to work with 0-degree scope, and I want to be able to see the frontal wall with my 0-degree scope. These were the mucosal flaps that we raised earlier on. And you can see there's a lateral component and a medial component. And I'm now fiddling around with them to get them into position so that I can cover up this exposed drilled bone that I've done. Jim said, and Aldo said, bone and air don't do well. You have exposed bone in the airway, it's going to get osteotic, it's going to create stenosis, it's going to create inflammatory changes, it's going to stenose down. So here I've got a bit of excess mucosa, which I will remove right at the end and use it as a free transplant. Used it right at the end, so it's been vascularized. It's been fed by the septal branch of the anti-ethmoidal artery. It's got good blood supply right to the end before I reposition it right onto the bone. Like Jim and like a lot of other people, I try and cover all the bone, and then I would put some silastic sheet towards the end just as a dressing. It just allows me in 10 days, 2 weeks time, when I see them, I just pull it out. Most of the rubbish comes away. The amount of work I need to do to clean up this area is significantly limited. I always put a stitch on mine, and I use soft silicone. I don't use very rigid silicone, just placing it in. Use the stitch because otherwise I've had one of my fellows leave one in there because they didn't find it. The stitch is then tied to a septal splint so that we don't lose the stitch, and it all comes out very easily. So draft 2B is now really my workhorse for this kind of procedure. Now, I would encourage you that if you do use this mucosal flaps and you do an adequate degree of drilling, you're really going to get good outcomes with it. The key things I think that have really changed frontal sinus surgery in the recent years is mucosal flaps. It's using flaps, whether it's a free flap, whether it's a pedicle flap, or it's a random pattern flap, or it's a pedicle vascularized flap. So I tend to use a combination of the posteriorly based flap on the septal branch of the anti-ethmoidal artery, which you can see here, and then also the lateral septal non-arterial based flap based on the lacrimal bone. And as Jim was also talking about the septum, the mucosa that comes in, you remove that, all that bone's going to go away, you tuck it away in the side, and then you can use it to cover up the exposed bone. So both of those flaps are really extremely powerful and useful. And Philip wrote up these, the lateral based flap, though Paolo was the original one which demonstrated on cadavic anatomical dissections. We used these combination of flaps, and Philip and myself wrote up a paper on our draft 2Bs, and we've showed that actually if you do the right technique and you use these flaps, your stenosis rate to 2B, which is traditionally thought to be, they all close down, is only actually of 4%. So I think it's a fairly good way of going about it. I'm going to just present to you a very interesting idea as a last point to you, and this is what I call frontal or fistulation, mucocele fistulation. Sometimes you have of pathology that do not are responsive to our kind of surgical therapy. And here, this is a gentleman that taught me this lesson. I saw him originally in the early 206-7, presented with a mucocele. You can see his eyes being pushed further down. He had quite significant neosteogenesis on the opposite side, a large supraorbital mucocele on that side. And then you can see that he's got multiple sequestrum, one in the frontal area, one in the supraorbital area. Obviously, he's got disease in the other areas as well. And you can see how old the surgery is. Remember these drills? We used to use them. And we used to go through about 3-4 of those per case because they used to ping off till we get the high speed drill, which now makes it so much easier to do, which is what you were looking at in the other. But here I thought I did what I was right at that time, created a big hole, opened up the supraorbital cell, made sure that made sure we can see that it's fully drained, had make that drainage pathway as big as possible. And then 4 years later, he comes back and it's all the same. It's all stenosed down again. So you can see that a lot of the bone was drilled away on the other side as well. Everything closed down in my draft 3, the supraorbital mucoceles back again. And the key thing is that pathway to the supraorbital mucocele through the ethmoidal complex is extremely narrow. And if the bone has been eroded away, then it will tend to collapse as the soft tissue collapses. I know you can have the orbital suspension technique, which Paolo is going to talk about tomorrow, but here I did something completely different. So what I decided to do was use this posteriorly based flap generated on the lateral wall here, and I essentially rolled the whole flap into a tube, drilled it all away, and then placed that tube as a fistula to fistulate that from the supraorbital mucocele into the nasal cavity. By bringing in healthy skin to cover the drilled osteatic bone, I tried to make sure that I was able to create a drainage pathway. So that was him afterwards looking. As you can see, he's got air in that supraorbital component. So although he's not got a pristine looking cavity, I can get that supraorbital mucocele draining away. So this is an interesting technique which I like to leave you with. It's called fistulation of mucocele, and we've used that quite a bit with craniopharyngiomas quite successfully, especially in the pediatric population where they tend to have a very cystic craniopharyngioma and they recur quite constantly. We tend to just simply fistulate them based on the Hadad flap, and that works extremely well. Where would I use it? This is another kind of case where I use it. You can see a laterally based mucocele with somebody who's got almost complete osteoneogenesis. Only thing you got is an intersinus septal cell. The rest of the frontal sinus is just new bone, but unfortunately isolated, and then the lateral component is a mucocele, and it's preferentially draining externally. So if you're really going to try and get this to drain to the midline, you have to drill all that away. But then you've got to make sure that that stays open. And what I then now tend to do is use the mucosal flap, drill that bone away, fistulate that lateral sinus into the midline, and that works extremely well in my hands and stopped a lot of the revision surgery that tends to come out. So in conclusion, I like to say, very important, the principles are very similar, whether it's a mucocele or any other kind of chronic frontal sinus disease. You've got to understand the anatomy. You've got to understand the challenges of this area. Have a structured approach. Look at where the pathology is. Look at what other cells they are. Look at the degree of osteoneogenesis. Look at the pathology you're dealing with, and then make a structured approach to what kind of procedure is going to be most appropriate here. Use the management grid if it helps you as a template, but watch out for those complex cases because they're going to come back and bite you. So I would have liked to have invited you to our frontal sinus course with Jim, Brad, Christos, Paolo, Philippe, Ashok, Shaz, and Chem. But unfortunately, with the COVID, it's going to be pushed back to 2022. So we'd love to see you all in Nottingham in 2022. Thank you very much.
Thank you, Professor Sama. That was excellent. Wow, some complex cases. And so we have some questions from our attendees. So starting out, especially I tend to agree with this attendee. You know that last case that you showed with the very lateral mucocele, do you ever perform external approaches for these? Or do you always tend to just try to, you know, connect those internally?
So when you're saying external approaches, it's an approach. So
Right.
you can have an endoscopic approach,
Okay.
and you have a open osteoplastic approach. I have nothing wrong with either approach because it's an approach. It's a way of getting to your pathology. The fact that you use endoscopes all the time doesn't mean you can't make a cut and actually approach the pathology. It is an approach. It's not an operation. The operation is whether you're going to create what size of antrostomy you're going to create. What are you going to do to the site? Are you going to drill it off? Now, if you're going to drill all that new bone away, what are you going to do with it? You're going to try and cover it with mucosa. Where are you going to get that mucosa from? If you're going to try and obliterate it, you're going to bury disease only to surface 10 years later when you've said goodbye and you moved on, and your next surgeon is going to come and take it. So I progressively over time, yes, I would use an external approach, but I would need to create some kind of drainage for that pathology into the midline so that I have certainty that it will continue draining.
Okay.
Does that make sense?
Makes sense to me. All right, and so because of this complex nature, especially of these mucoceles, and a lot of time you have the bony remodeling, how often do you encounter CSF leaks? And then when you encounter that, how do you manage to repair that and then oftentimes still keep the mucocele from collecting at the same time? Does that make sense?
Yeah. So usually you will see large areas of dehiscence related to the mucocele. Okay, it is extremely rare in my experience, and that may not be true, for actually that part of the dehiscence to be the area where you get the leaks. It's not the dehiscent area that leaks. It's actually in your way of process of accessing the pathology that you will tend to create your leaks. Okay, so my key way of managing them is using mucosal flaps. Okay, if you're going to have a narrow LP AM dimension, you're going to put a drill in there, you do enough of these, you are going to create leaks. That's the nature of the beast. But if I tend to rely very much on using the flaps, so I'll do two-layered closure, and usually it's the posterior or the medial component that where the dehiscence or you create the leak from, and I would tend to use my flap, which I will use to cover up the bone anyway, but I'll also use it to cover up the defect in those areas.
Now, when you say flaps, let's talk a little bit more about that. Are most of your flaps pedicled flaps, or do you ever use like free mucosal flaps?
Both. There are three types of flaps you'll use in the frontal sinus.
Okay.
You'll have a vascularized pedicle flap, which is based on the septal branch of the anterior ethmoidal artery. You've got a random pattern flap, which is the septal, which is based laterally on the lacrimal bone, goes over the roof of the nasal cavity, come to the septum. There's no defined vessel on this. If you've got to keep the width, the pedicle wide enough so that you've got good vascularization, that's a random pattern pedicle flap. And then you have free mucosal grafts. So I'll use all three of them, and actually all three of them work.
Okay.
The more pedicle they are, the better they are. The more vascularized they are, the better they are. I tend to avoid the inferior turbinate because I find it's very thick. And if you start debriding it or trying to thin it, I wonder about the integrity of the mucosa. So preferentially, I'll tend to use a very thick septal mucosa. Preferentially, I use floor of the nasal cavity, or I'll use these pedicled or harvested flaps from those areas.
Okay. And so just to kind of reiterate, remember when I asked the question about the external approach for that lateral mucocele? And so it sort of ties with the evolution that Dr. Palmer talked about. You know, a long time ago, we would do a lot of obliterations of just really diseased frontal sinuses. Did you ever do that? And over time, did you get away from doing obliterations? And if so, was it because of just retained mucosa?
I try and avoid obliteration at all expense. So all the ablative procedures, so the 3 ablative: obliteration, Riedel's procedure. I have performed several Riedel's procedure, and that's very good in very specific kind of pathology. You've got small frontal sinuses, recurrent osteomyelitis. Riedel's worked wonderfully in my hands in somebody like that.
Can you explain that to the attendees that may not know that procedure?
So there are 3 types of ways of ablating the frontal sinus. Making it non-functional, you're just getting rid of it completely. You can either take the frontal plate of the frontal sinus off, which is called the Riedel's procedure, and leaving the back plate, so you keep the frontal sinus extracranial, but the soft tissue then flaps back in and obliterates the gap. Now, the problem obviously is that if you've got a deep frontal sinus, you're left with a very deep cosmetic defect from the collapsed soft tissue. So you've got to be careful, or you've got to think about reconstructing your titanium plates in the future. The second is, which unfortunately a lot of our neurosurgical colleagues like to do, cranialization. So rather than taking the front plate off, you take the back plate off and drill off all the mucosa and cranialize the frontal sinus. So you obliterate the floor and the etc., and you let the brain cavity take over the area of the frontal sinus. Or lastly, which is the obliteration procedure, as we know, where we take the frontal plate off, fill it up with fat, fascia, whatever you want to do, obliterate it, and then put the frontal plate back, and that's an obliteration. So 3 ways of ablating the frontal sinus, entirely the last resource. With the spectrum of techniques, the instrumentation, the anesthesia we have nowadays, that is really very much a last resort in my practice.
Well, thank you very much. Due to time, we have to proceed on to our next great speaker. We really appreciate it. Thanks again, Professor Sama.
Thank you very much.
All right.
The head and neck surgeries you perform are vital. Your patients place their trust in you. You help them continue to speak and smile, eat and drink, hear and comfort. You're committed to helping them continue to live fully, to feel deeply, and to enjoy the quality of life they've come to expect. That means being confident that you're protecting and preserving your patient's head and neck nerve function during procedures. Introducing NIM Vital, the next generation of nerve monitoring technology. NIM Vital provides advanced nerve monitoring that helps you reduce the risk of nerve damage during head and neck procedures. Detailed intraoperative nerve condition information helps inspire your surgical strategy. An intuitive user interface with a wire-free patient interface allows for easy setup and enhanced visualization from the surgical field. Real-time notifications of nerve conditions, visually and audibly. Green, yellow, and red status bars provide visual information, and their associated tones provide audible cues, making monitoring function easier than ever. NIM Nerve Trend EMG reporting enables nerve condition tracking throughout a procedure, even when using intermittent nerve monitoring. And when paired with a NIM continuous monitoring electrode, you have continuous nerve monitoring informing your surgical strategy. NIM Vital pushes the boundaries of monitoring nerve function in various procedures in head and neck surgery, with real-time information available during surgery, giving you confidence in nerve function. Because protecting patients' nerves and senses is more than vital. NIM Vital.
imagine? What if you could do even more to bring relief to your chronic rhinosinusitis patients? With technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System. A customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options. With flexibility in hardware design and optional software functionality, get everything you need and nothing you don't. With Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.